Good morning, ladies and gentlemen. My name is Denny Brennan. I'm the Executive Director and Chief Executive Officer for the Massachusetts Health Data Consortium, and I want to welcome you to today's webinar featuring J.C. Gonzalez from the Satcher Health Institute, who is joining us to discuss and demonstrate their health equity tracker. Before we get started, let me share a few details with you about today's webinar. We will be live tweeting during the webinar and invite you to participate, as well as using the hashtags and handles that we will show on the next slide. If we can change to the next slide, that would be great. As you can see, we have the Satcher Health Leadership Institute's Twitter handle, the Twitter handle for Mass Health Data Consortium, as well as the hashtags that you can use if you are so inclined. Today's webinar will be about 60 minutes in length. We will take questions throughout, but we should also have time at the end. So please ask questions as you proceed through the webinars so that we can ask those of JC and get your questions answered. This webinar, as you know, is being recorded and will be available on our website in a few days. You're in listen-only mode, so please put your questions in chat and we will answer those for you as they come through. We might answer them along with others in the form of a consolidated question. If we get a number of questions that are similar in content, we may combine those and your questions will be answered in a way that it sometimes might sound not quite exactly the way you framed it, but we're attending to all the questions that come across the board. Finally, we appreciate your completing a survey that we will post after the webinar. It takes a minute or less to do, and it enables us to continue to offer great webinars like this. Lastly, our next event will be an interview with my friend and colleague, Roberta Schwartz of Houston Methodist Hospital. If you don't know Roberta Schwartz, you should. She is one of the finest healthcare executives in the country, having done things at Houston Methodist at the height of the first COVID pandemic before the vaccines were released to deal with a flood, an enormous flood of patients who needed intensive care treatment way beyond the capacity of a hospital, even as large as Houston Methodist. And her work in virtualizing ICU and enabling physicians to treat hundreds of patients in COVID isolation across multiple institutions is really inspiring work. And she's done many other things. And we think, and I know Roberta as a person of extraordinary character and strength of purpose. And that's what we want to talk about in our Vantage Point interviews. So we hope you can join us next Monday, October 3rd. You can register on our website. So please take a moment after today's presentation to do that. I guarantee you, you will find it to be a very exciting and informative, compelling discussion. So now it is my pleasure to introduce J.C. Gonzalez. J.C., rather than me going through all of the great things you have done, why don't I let you introduce yourself and we can then turn the webinar over to you.
Thank you so much, sir, for the opportunity this morning. Thank you to you all. You may notice my voice. I'm fighting not to lose it, and I think I'm losing that battle, but I'll do my best to slow down so I could be understood. As you heard, my name is J.C. Gonzalez. I'm the product manager for the Health Equity Tracker at the Satcher Health Leadership Institute. I spend a lot of my time working to understand the challenges and opportunities around health data, and specifically around defining equitable data practices, and how can we bridge the gap between data collection and reporting, and translating that into actionable solutions. As a product manager for this platform, my job really is to develop, guide development to build the right things at the right time, to support the work being done by so many amazing organizations, advocacy groups, community leaders, policymakers, Anyone that's working to advance health equity, we want to give them the data and tools that they need to not only make their arguments more persuasive, but give them more opportunities to have evidence in the data. So with that, I wanted to start with the vision for the health equity tracker, and it really began with a simple question that you see on the screen. And the question is, what could we do with a platform that places health equity at its core? What kind of new data decisions would that drive, and how would that change the way data is presented? What kind of unique visualizations could we develop? And the goal is really to demonstrate the very real health inequities people of all backgrounds face. And again, I mentioned it earlier, but not only show the outcomes in the data, but take it a step further and draw a link to the root in those outcomes, whether through social or political determinants of health. And then finally, the clear drive to action is, how can the people closest to the problems be part of the solution? How can we draw a clear recommendation that supports action to using this data? So with the support of our partners, we've embarked on a research study to really dig into the data landscape and really support our vision for a health equity first platform. Over the past year, we've learned a lot, and it seemed really logical to start with the challenges. And I'll read a few. There's so many of them, so I won't spend a lot of time, but the first question that we kind of grappled with is, what does equitable health data even look like? You know, how's that different than what's currently out there in terms of data platforms? When we think about interoperability, how can we incentivize organizations to share data, or how do we make data exchange easier and facilitate those kind of communication channels? Health equity, you know, it's really interesting. We're really communicating cross audiences and cross industries, and each stakeholder has different needs, not only for what they want to do with the data, but really the time and place. For example, a physician that's providing patient care has different data needs than maybe an outreach worker that's working in their community. So how do we support meaningful use? And what I mean by that, again, is not only here's the data, but how to use the data. You know, we want to take it a step further. It's not simply enough to present the outcomes. We need to take the extra steps to ensure the people in our target audience understand it, can use it efficiently, and has value in the data. We've learned there is huge variation in data collection, not only at the point of care of how the data is collected, but also in how it's categorized in the data set. So again, we need to understand what are these variations and inconsistencies, because it really limits what we could present and draw comparisons from. The greatest kind of need for us as a health equity is really drawing fair, representative, apples to apples comparisons, and that's really challenging to do when definitions are non-standard and there's very large variation in the data sets that we use. I'll do a couple of these together, but we know unconscious bias, institutional mistrust, systemic racism, politicization of data, it all impacts the utility of the data. So all these are very viable concerns that really drives a lot of context into our communication strategy of how do we not only show the data, but what are the important kind of conversation points around the data? What are the concerns, the challenges, and strengths, and ensuring that we are communicating and speaking to those needs. I think the final one I'll touch on is lack of standardization. This is a big one for us with health equity. Depending on which data set you use, and what we built the health equity tracker for is to find the best sources of data across the internet and bring them into a single platform. And we think that idea could be really powerful. The problem with that is that the definitions are non-standard. So one example that I use is when you talk about Hispanic ethnicity, in one data set, that might be a standalone category of people. And another one, those might be combined with Black Hispanic or white Hispanic or different, variations of that. So when you're trying to combine them into one platform, you need to really be sensitive to what is the definition in this data set, and is it a fair comparison to put them side by side due to variation and that lack of standard definitions.
JC, I have a question for you on that. Can you speak a bit more about how you make sure that you're comparing apples to apples when you get different and possibly inconsistent data? What do you do to sort of transform data so that you are comparing apples to apples when you get inconsistent data? What are some of the methods that you employ?
It's a great question and a great challenge. I mentioned earlier, we don't do any data collection ourselves. We search, publicly available data sources, and typically, if we don't find a data dictionary along with the data set, a lot of organizations will publish that. They really go to their methodology of here's how the data was collected, here's the definitions of the terms. Our team either reviews that really carefully or will reach out to the data owner, and we've had a lot of success in collaboration that if we have a question on the data set, we speak directly to the people that maintain the data set. And we've had really great conversations and transparent conversations around these challenges. But I think the bottom line is that if we can't discreetly define the definition or the term, then either we don't use it at all, and that's a great trade-off. If we don't have confidence in the data that we could speak to it, then we might not use it at all. Or we do a lot of work into adding contextual information. So a lot of platforms do definitions, but then we do the extra step of saying, here's what it means for health equities. So an example might be small populations. A lot of data platforms, they'll say, this is a survey, not enough respondents to be representative. And that's pretty much where they end with the definition. For us, we really say this is a health equity issue. These people are not represented due to population sizes. So rather than put a footnote that's a limiting factor, we really try to raise attention that, hey, there's a demographic group here that's represented in the data. Here's why. Here's what you could do to help representation issues. I hope that answers your question, but there's really not a magic. It's not a magic bullet. It's a lot of work to really try to dig into understanding the data set.
Great, thank you.
Thank you for that. And please, any questions? Please give me a break from speaking because my voice is.
Yeah, that's one of the reasons I asked the question. Was I thought I'd give you a break from speaking. The only trouble is you have to answer it.
You're right.
And then you get to talk again. So we'll do our best.
Thank you for that. So on the last slide, I don't mean to only say, here's all the problems, and the title of this slide is kind of negative too, and the problem space is huge, but really there's a lot of optimism for the future. And the reason for that is when you think about health equity, very little of what influences our health happens in a hospital or in a doctor's office. It's determinants in our environment, where we live, where we work, where we play. Examples, like transportation, having reliable transportation, how available do I have healthy food in my community, security, do I feel safe going on the sidewalk and exercising? So a lot of these things, you think about it, those are the behavioral factors that have much more impact into health. There's also political factors, so decisions from a policy perspective, or the decisions made or not made, where to build a highway, an example, where to locate big industry, and how does that impact nearby communities? Where do we create green spaces, plant trees and have parks and things like that? Those are all decisions that are made either through civic planning or other channels. But the reason why we're optimistic for that is because it gives us a lot of creativity, diversity into how we approach these problems. So when we talk about that, we're really excited because we could be just as diverse. And how do we tackle these challenges? And on the screen, I have a few of these guiding principles that we've really defined over the last year. I'll start with defining equitable data collection and reporting practices. We feel there's a lot of research opportunity and thought leadership into defining what are the metrics that are important for health equity. What are the data fields that we should be asking and collecting? What are the standard kind of definitions that could be adopted, not only for our platform, but for health in general and health equity in general? What are these standard, important, consistent questions that should be questioned and answered? The next one is reducing and removing barriers to data. An example that I really enjoy using is for our COVID-19 data, we use a file from the CDC. It's a single file that is hundreds of thousands of lines of data. And if you think about who's the audience for that, it's not really policymakers, it's not really people in the community trying to understand the impact of COVID. It's not an accessible way to access the data. It requires either some technical knowledge, how to work the file that big. You need to take steps to translate that into information. It really is just raw data, and it's really hard to understand what is that actionable intelligence from that. And again, if it's not a technical barrier, it's just the data analytical barrier. Is how do I make sense of such a huge file? So we take a lot of thought and caution into taking files that are big or not easily understood and present them in a way that it's easier. So a lot of those ways we'll generate a graph, do some unique visualizations, which I'll show in the next slide. But really, it's all about maintaining the representation in the data set and making the evidence easier that you could, at a glance, get some actionable intelligence from it. But if you want to dig into it, you do have the skill set or the team, you could go deeper. So it's really kind of layering the accessibility. It's you have certain people that need a little bit more visualization and reduction of the technical load, which is what we do, but it's not at the cost of the fidelity of the data. For the teams that want to use the raw data, you could do that as well. The third point is really effective messaging. And we spend a lot of time in thinking, how do we speak directly to our audience and speak to their needs and their problems? It's really common as a product manager. I look at this platform every day. I try to look at health data every day and what the organizations are doing and the data landscape. And it's tempting for me to implement ideas that I think are good ideas, but really my ideas don't matter as much as the people doing the work to advance health equity and the challenges they face and the opportunities they feel that are needed. So really, we try to speak directly to our audience. And the question is really, what is the work you're doing? What tool do you need in your tool belt that I could help with to make your argument more persuasive or give you more evidence to support the work you're already doing? So it's not necessarily implementing data because I think it's a good idea. It's really what is the work ongoing? Where are the gaps, and where can a tool like the Health Equity Tracker support you? And we do a lot of work to have those collaboration opportunities with the people doing the work. The final point is really my favorite, is sharing what we learned. So this is a really young field, and I know data in general, we generate, in healthcare, huge volumes of data. Organizations, not only healthcare providers, but payers, all these different stakeholders. It's become a challenge into grappling with the volume of data. How do we really use it? So we really, get a lot of value from talking to people that are facing the same challenges. As not only is there so much data, what do we do with it? We have roots as an academic institution, so we really want to spend a lot of time into sharing what we learn, helping others advance health equity, and there's a few ways we do that. Our platform is completely open source, so you can log in today and you could actually look at our code and make suggestions into what we're doing. You can see where do we get our data from, what is our thought process. Our engineers really kind of detail comments and say, why are we managing the data in certain ways? And the reason we do that is for the spirit of collaboration. We want to help others advance health equity. Our director has said in the past, our goal is to be obsolete, either because health equity it reached a point that it has momentum and we've confronted the disparities in health outcomes, or because we've helped so many other organizations really infuse health equity minded philosophies into their data platforms as well. So that would be a great success for us as well.
JC, we have a couple of questions, and I'm going to ask these questions slowly so you can drink some tea and you can rest your voice a bit. But one of the challenges that you raised on the previous slide related to data collection. And in our experience as a consortium, as you pointed out, this is a young field. There is a lot of mistrust in the community at large about questions related to health equity, questions related to their race, ethnicity, gender identity, sexual orientation. You can go through the list. There's a lot. What are some of the insights, even though you're collecting data, even though you're looking at data that has already been collected, you are encountering these kinds of challenges when you talk to the community. What are some of the insights that you could share with us as we, as a consortium, as we undertake health equity related efforts that will allow us to speak effectively and invite people in an engaging way to share this kind of information, knowing that we're, how do we build trust? I think is one of the underlying questions. Could you talk a little bit about that?
Thank you for the break. It's such an important question, and what we've heard often is, how will my data be used? There's not a lot of understanding on behalf of the patient or the person volunteering their information is what are we going to do with the data? Who's collecting it and for what purpose? So we feel that there's a lot of communication that could happen at the point of care. If it's survey data, giving more context into why are we collecting this data, what are we collecting? Because a lot of the concern is identifiable information being shared, which is a real concern for small populations. Even if you don't share name, address, just the fact that you are a small population in a certain region could be identifiable. So there's a lot of communication that could occur. Why are we collecting the data? What is the purpose? How do we share our data? Who owns the data is another important thing. There's a large kind of movement or concern is the patient data. Is the patient the owner of it, or is it the healthcare provider? So it's a lot of ambiguity in those kind of activities. From what we've learned is from a data platform perspective, is share what is our purpose for the data, how do we manage it, and for us specifically is by the time it's de-identified, and we clearly state what are we using the data for. The other part of this is really the mistrust, and there's a history of people having institutional mistrust given what has happened to either their families or generationally. It's hard to overcome that barrier of mistrust, and we need to take steps into rebuilding it from a lot of perspectives. So
thank you. That's really helpful. One of the other questions we have is a more technical regulatory question, and that is social determinants of health data are included in the US CDI version 2 coming out of the Office of the National Coordinator for Health Information Technology. Is that a plus or a minus in your estimation? Is that an effective approach to collecting these data, or at least establishing standards? And do you see it impeding folks from sharing sensitive data when it starts to become part of a more general data collection effort on the part of healthcare organizations? As you said, we don't know who owns the data. It's a debate in progress, but the US CDI is going to be the data that's required to be shared among healthcare organizations and patients. And SDOH data are in version 2. What are your thoughts about that?
I'll have to get more familiar with that data set, but in general, there's a concept of population health, and by virtue of a hospital existing in the community, the populations around them should be healthier. And things like SDOH, social determinants, is an important driver of the outcomes. So I think for us, we want to get to the point where we show the outcome data, but we also give contextual information on what may be driving these outcomes. So social factors, that's critical, and that's strongly evidenced in the data. I think it's important to share and draw that link. The reason why I mentioned population health earlier is because it's not line level patient data. It's more outcome based in terms of population. So diabetes community patients, that demographic, what are providers in a certain region doing to advance chronic treatment of diabetes? A lot of those things are not in the hospital, they're in the community. So those SDOH factors are very central to that, and it's an important data element to consider. So I'll make a note to get more familiar with that data set specifically, but in general, I think that's a broad aim of the Health Equity Tracker and other organizations that I'm aware of.
Thank you.
Okay, thank you. Great questions, and thank you so much for that. So this is a very concise way to express our vision. And it really boils down to this: if policy influencers, and the term policy influencer is something that we came up with about a year ago, and really it's just someone with a motivation to advance health equity. Someone that could influence policy wherever they may be. It may be data analysts, maybe pharmaceutical, commercial interests, advocacy groups. It doesn't matter the space that you're in. If you have the motivation to address health equity and health disparities, then you're a policy influencer. And what we want to do is make the data more easily find, so you can find it more easily and communicate them. That's the other step. And then the second part is those policy influencers will be more successful in supporting action from policymakers. So that's a very kind of interesting relationship. When we talk about policymakers, we really think about people in a position of power to act on either a policy, from an organization standpoint, or political. So really, there's a relationship here where people communicate the inequities that they think are important, or the outcomes and health issues that are important to them, and they are communicating that to someone that's in a position of power, whether that is a hospital leader, someone that's a representative, but it's really drawing attention to it, giving them the evidence, so ultimately those action steps could be taken. So we thought this was an important slide to really kind of concisely state what our vision is. The next one, again, is what are these principles in action? So on the right, you see a little bit of our webpage. Really, we're working to identify the best sources of data from across the internet And the power of the health equity tracker is now we combine them onto a single platform. We've done user research interviews, and I forget the number right now. Most people are juggling multiple data sets, multiple websites, multiple reports. There's a lot of value in bringing them into a single platform where we could give representative summary data, but then also link you out to different organizations that are managing data. So it gives us an opportunity. Number one is to widen the audience for the data. We could give more context into the drivers of the outcomes, and then make recommendations. Here are other data sets or practices that are doing work that you may find useful. So we launched in May of last year, a little over a year ago, with 5 topics. We've expanded the health equity tracker to over 18. And that really demonstrates the promise of the health equity tracker. I think that was intentional. When we started with 5, in just a year, we broadened, almost more than tripled. And that really is the exciting part of health equity. Is there's a lot of ways we could add data to the platform. So whether it's environmental issues, commercial interests, health outcome, chronic disease, and things like that, they all have a space on the health equity tracker. And really what becomes powerful is that by having them on a platform that is standardized and comparative, you can really do those comparisons one by one. I'll show you on the next slide an example that I like to use. So this is the state of New York COVID-19 death data. And this is a chart that we developed, and we hope is an example of a health equity-minded visualization. So the dark green bar that you see for each demographic group is the percentage of deaths. The light green bar is the percentage of that demographic group's population. So if you look at this, Black or African-American individuals, they accounted for a little over 22% of deaths in the state of New York. However, they only account for 14% of the population. And when you look at the Hispanic Latino community, they accounted for 25%, almost 26% of COVID-19 deaths since the beginning of the pandemic. They only account for 19% of the population. So if you put this in context, Black or African Americans, they account for less than about 30% of the total population for the state of New York, but account for almost over 50% of COVID-19 deaths. So the intent here is really to show the outsized impact. We've been calling it the undue burden of disease, that certain demographic groups are dying at a higher rate, even when you consider their lower total population. So this is an interesting chart. I'll show one more. This is another example. And people think about health equity, and there's a false narrative that health equity is solely a race issue. While that's true, health inequities by race has a long history and strong evidence in the data. The health equity movement overall, it's really from people from all backgrounds, and it includes breakdowns by age, by sex, socioeconomic class. When you think about rural communities versus urban, poverty, disability. So these are all populations that have disparities in health outcomes. So this chart that I'm showing on the screen is really a breakdown by age. And if you look at it, we can infer, that the data shows for younger families, especially for households with children, they have experienced poverty in higher rates. A reason for that, look at the health equity tracker, is the children, are counted as living in poverty. Families that tend to have children younger now have generational poverty. And that's really strongly evidenced in the data that I'm showing here on the chart. You can see poverty rates tend to skew younger. And the intent here really is to give policy makers, community leaders, researchers, different views into the data. So whether you can look at poverty by race, you can look by age, you can look by sex, really it's the flexibility to have people draw their own comparisons that they could dig into the areas that matter to them.
JC, that chart that you just showed has a very sobering statistic on it, which is almost a third of young children, 0 to 5, I believe, 30% or 28+% are in poverty. That's a terrible statistic. And if poverty is a social determinant, which it is in so many ways, this is going to have a profound effect on people over the lifespan. Are you looking at ways to follow populations and to see how their situations improve with respect to income or economics, as well as some of the other social or political determinants of health? I mean, children are really on the receiving end of the worst of this, young children, and it doesn't bode well for a future. Any thoughts about that?
It's really sobering, and there's evidence of this throughout different data sets. As you were speaking, we also have a data set on incarceration, and there's a large number of children incarcerated in adult prison facilities due to variance in local jurisdictions. So that is not juvenile detention. Those are children in an adult facility. And I think, again, this is the advocacy movement of the Health Equity Tracker. We could really show strong evidence of issues like that are so important. To answer your question about tracking, it's funny because we're called the Health Equity Tracker, but until now, we weren't really showing changes over time. Really, the reason why is because the data quality is such a barrier to be able to follow certain populations over time and understand, are things getting better or worse in terms of outcome. We're launching actually next week a timeline feature for COVID is where we're starting. We hope to expand it to poverty and all of our data sets, but we hope it achieves exactly what you were asking is, from a population level, where is the data trending? Are communities getting healthier in terms of poverty? Are the same age groups over time? Is it still skewing young? Is it changing over time? Is it getting better or worse? So we're launching in phases. The first one, and I'll be happy to share with this group once it launches. It's going to be COVID-19 cases, deaths, and hospitalizations, and we hope to expand that into the future because it's such an important insight. Is are these outcomes going in the right direction? Are advocacy efforts helping or hurting, and what are the kind of actionable things that we could do? But yeah, when you look at it inside like this, it's really sobering, and it's really not always evidenced or not always very visible in other data sets. And I think that's the power of a health equity lens on this, is the outsized impact really is important to draw to the spotlight and really present it strongly. A lot of data sets for COVID especially, they'll show total cumulative counts. So like, here are the number of people with COVID. We think that's a problem because small populations might have very large prevalence of COVID for their community, but the total count is not as large. But when you put that in context of their neighborhood or community, or just their demographic group, it could be very, very high impact. So things like that is a very health equity perspective into data sets like this.
Another question we have, and this is, and I'm speaking slowly so you can have tea, and I can do everything I can to ease the speaking burden that you have, even though you have to answer these questions. So maybe it's a double-edged sword. But you talk about at Satcher, you talk about political determinants of health, which is a really interesting and I think compelling perspective on inequity. Social determinant, when we say the term social, it sounds like it's in the community. It sounds like it's sort of enclosed within particular communities. It's generated by those communities and the different social forces they have to deal with: transportation, housing, food, but yet there are larger forces at work that incarcerate children, that allow children to be in poverty at an abominable rate. Could you talk a little bit about that notion of political determinants of health? Because I think that steps outside of, it's social, it has to do with the community, and ignores the fact that there are larger forces, and some of which are very intentional, some are not, but some are, that make the that subordinate social determinants, that make it very hard for social groups, communities and neighborhoods, zip codes, whatever we want to characterize them as, to get out of the inequity trap that they're in. Can you talk a little bit about political determinants of health?
Our director at the Satcher Health Leadership Institute, Daniel Dawes, is really one of the great leaders in that space and could do this topic much more justice, but I'll do my best. The idea is these disparities are driven from a political action or inaction. So when you talk about social determinants of health, those are the conditions, right, in community. But really, that's not the end point. The end point is layered deeper. And a lot of the times it's from a policy decision that was made, either from a civic decision, urban planning, business decision. So a lot of these things are correct. They don't have to exist. I'll use an example as you were speaking. I'm in South Florida. On top of my voice, there was a hurricane passing through today. And the reason why I mention that is because some communities in South Florida are better prepared to deal with the hurricane, or they take longer to recover after the hurricane. Now, that is not inherent into, just the neighborhood's different. Those are policy decisions, those are political decisions to either prepare the neighborhood adequately or to recover correctly, and where are those resource allocation decisions made? So that's just one quick example of, yes, the social determinant is hurricane preparedness, but the political determinant really is what is our decision points to really prepare the community or help the community recover quickly. I'll use one more example. We talk a lot about climate change and heat waves, and this is something in the Pacific Northwest that's very it's life endangering. People die from heat exposure very when temperatures rise. And when you think about the communities that don't experience heat change quite as drastically, it's those communities that have more trees, that have more parks, that are maybe local to bodies of water. And by contrast, the communities that experience more fluctuation in heat have more asphalt and concrete. Their buildings are, constructed with less energy efficient, practices. They might be closer to industry that produce, things like that. There may be communities that, disability community that this happened last year, where the heat was risen to a certain point where public transportation shut down temporarily. So you think about, okay, the communities that rely on public transportation now have a very urgent need if they cannot stay put and weather the heat exposure. Now they have a secondary problem of how do they relocate somewhere else because the public transport shut down. Now the public transport was a political, decision. It was a policy decision that was made. So again, I hope that is clear. The social determinant really is the conditions of it, but the argument that Daniel Dawes makes often is that that's not the end point, and these kind of conditions don't need to exist. They could be rectified either by the action or inaction by someone in the position of power. along the chain. I hope that was helpful.
No, that's terrific, because it is. I mean, social determinants are you know are caused by major decisions, whether they're intentional and hostile or not, that burden communities disproportionately. We have a question from Brian I'd like to ask, and that is, there are many questions. I'm sorry, there are many aspects to health equity, like you mentioned, social determinants of health, political determinants of health. There's age, sex, race, ethnicity, language. Can you speak to how you narrow in on a metric that may have the largest disparity, that for you stands out as a signal more than maybe others? Do you examine every single metric? How do you determine if the results that you're looking at are statistically significant? Where do you look to find differences that are real differences, and which ones stand out the most?
It's a challenge and thank you for the question. It's a challenge that we grapple with every day. In terms of what we collect, we look for data sets that have a formula, essentially. We need race and ethnicity. We need geography, which we try to get down to the county level, because we feel at the county level it's the most actionable, because you can send that data to a representative at the county level, is localized. And then we need a topic, a condition to track. So whether it's COVID or comorbidity data, asthma, diabetes, things like that. Really, the driving kind of limiting factor is data quality, and we spend a lot of time creating almost like a repository of data sets on different topics that have, at minimum, the data that we need to use it. I think, to answer your question more directly, we don't look at every single metric. We try to look into the topics that have the most known disparities in care, already evidenced. We try to support that through data. We work often with advocacy groups and experts. So I say often, I do have a little bit of a background in health equity, but I'm more technical in experience, but I'm not an expert. So we look for those experts. For example, in behavioral health, we formed an advisory to really kind of explain what are the issues with behavioral and mental health, what topics are important. And then we do the research. We say, okay, well, given these topics, these are the data sources that have the information that we need. And then we'll go after those kind of low-hanging fruit for now. In the future, I would love to expand that and really state, if we have the data, one of the visions is really anyone can plug in a data set into the tracker and produce like a chart or a table from that data. But I think really is we rely on the expertise from these advocates to really explain, here are the challenges we know exist. Can we partner with you to find the best data? And then we try to support those movements in that way through partnership. I hope that answers your question.
It does. Thank you. Let you continue.
Okay, thank you. So I think this is almost my last slide, and it's really the question of how do we measure progress. And when we launched the tracker, our kind of success metric was we are successful if we are supporting policy that advances health equity. The problem with that is that policy moves very slowly until it doesn't, and then it moves very quickly. So how do we measure that? And what we learned is really what we should be measuring is engagement. And we had the amazing opportunity to work with experts, from the White House, from the CDC. We worked with Google.org, really more than I could mention, but really it's engaging with these advocates that are mobilizing these groups. We think it's important to form coalitions and really use that passion as the driving force into those topics that we dig into. So to answer it more directly, how do we measure progress? Here's my best attempt is we must identify the important metrics that matter for health equity. So we are making recommendations from a data level, which data fields should be included in an equitable data set. And I'm using air quotes for that, but we want to almost grade data sets and organizations and saying how equitable is this data set, and have a justification why we think those representation issues were considered, the health perspective is included, and at least part of the decision-making process. And we think that there's an important opportunity to define and promote the adoption of those practices. The second thing, and this is really a huge area for us, is name and put a spotlight on the data gaps. So we know every single data set we've seen, if someone knows one that doesn't, but every single data set has gaps. And a lot of those gaps are footnotes. And we think that's a problem. We want to say very broadly and visibly what data is missing, who is impacted by that missing data, where do they live, where are they located. And we feel that by establishing clear boundaries on what we know and what we don't know, we could really drive more equitable solutions. I've been trying to get this catchphrase to catch on, so maybe you guys could help me, but I've been saying that data gaps is not a technical issue, it's a health issue. If we don't know more about the people and their conditions and the outcomes, a lot of people think that's just data quality, that's the landscape of data, and it's kind of inherent these gaps exist. But I really want to stress that it's not solely data collection issue, it's not solely technical issues, it's a health issue because the limits are understandable. And I think Denny, you mentioned this earlier, and thank you for doing that. We want to connect the evidence in the outcomes to the root drivers. And I think I say this every presentation, we should not just present the data. That's not enough for health equity. We need to supplement the data with context and the nuance to what are driving these outcomes in the first place. So we think about health equity again, SDOH, PDOH. It's not enough just to say, here's the outcome. Here's the data that we do know. We need to draw the link to the root drivers. And really show, why are these things happening, as best we can.
JC, we have a little more than, and I think you're bringing this up, we have a little more than 5 minutes left, and we have a couple of questions. But one of the things I wanted to ask you, and I don't mean to spring this on you by surprise, but are you able to show us the tracker and walk through a slide or a visualization or two?
Yeah, absolutely.
Over the next couple of minutes, I think people would like to see what it is we're talking about and get a sense. And then afterwards, I want to ask you a few technical questions before we conclude for the day. So just a few minutes would be great for people to get a sense of what it is we're talking about.
Let me stop here. Okay. Can you see my screen?
Yep, I can see your screen fine.
Okay. So yeah, I'll do a very brief. This is a little bit challenging because again, it's complex in nature. But when you land on a health equity tracker, really, this is where you would interact with the data. You click on explore the data here, or we have the button here. Now, when we talk about accessibility, this is really a very tangible way we express that. A lot of these data platforms that you use, that people use, there's a ton of filters and toggles and select my topic, and how do I even get to the point where I see what I want to see? So what we did develop is what we've been calling the MAD, which is in one click, you can tell me investigate rates. With one click, I could express to you our categories and then the specific topics under those categories. So if I were to click the say incarceration, now all the data underneath is incarceration data. So as I scroll, these boxes we've been calling cards, which is a discrete kind of data output. But as I scroll through this now, I'm doing, incarceration. So this has given us already excellent feedback because I'm not digging in at all. I'm really just saying, oh, I'm interested in depression data. I have one click and now the whole page is giving you, enough for you to get is our hope. The second variable is geography. So I'm going to go back to incarceration. By default, we do national, but like I said, we do state and county. So I'll do Florida, so that's where I'm at. And now you see, based on that, again, everything is based on this solution up here. So I'm showing incarceration in Florida. I think in the interest of time, I'll show you guys the map and then I'll pause there for if
Yeah, I
anyone
think this, and I think this is enough. We don't want to, demos
Okay.
are hard to see on the screen, but we did want to get a sense. This is very novel too, the way you've been able to ask a simple question with a couple of variables and give the user the ability to control those variables. I think that's really useful. We have only a couple of minutes left, so
Okay.
I was curious. I just wanted to take a look, and I appreciate your sharing that with us. But let me get to a couple of questions before we wrap up for the day and before we conclude a really outstanding presentation. One is, can you speak to how the Health Equity Tracker was developed? What kind of technology you used? What were the tools? You speak as a technologist. Can you talk to, both from the back end perspective and the front end visualizations? Do you recommend a toolkit for others who are working with health data that would enable them to produce results or produce visualizations much like you do?
So you'll stretch my technical limit, knowledge, but I'll do my best. So we source data either manually, where we go and we find and we ask the data owner from an organization either for a download or for an API. We convert that into a table that is a Google BigQuery, and that's really where we kind of apply our standardization process. We normalize for small populations. We any kind of data concerns, we kind of triage it there. In terms of technical stack, I know we use React for our maps and visualizations. I'm not sure anyone's familiar with that program, but rather than lead you incorrectly, I'm going to link our methodology page in the chat. If you guys can help me share that, where we put our GitHub, which GitHub, if you're familiar with, is really where we manage code. And it goes into great detail of what we use and specifically technical kind of process. I would invite you all to look at that, and I think that would do a much better answer than I can.
Well, we will do that. That's a very good answer. GitHub is a very, very important resource, and we can look into that and make that link available. And I see you've added that link, which is terrific. Thank you for that. I have time for one more question before we hit the top of the hour. And this is a big one. So spare your voice and speak in code if you want to save your voice. But what are the 2 to 3 things that you'd most like to see the Health Equity Tracker do that it doesn't do now? Are there things that you are just thinking of, this is the next thing I want to have the Health Equity Tracker do? What comes to mind?
The big one that we mentioned earlier, I gave a sneak peek, is time tracking. It's almost a given that Health Equity Tracker should track time. And at the time, the technical part of it were too much for the team that put it together, but we're reaching a point that we're able to do that. And we're really producing, it's not just a line chart, it's really a novel way to show tracking, and I'm really excited to share that. So I think that's the biggest thing that comes to mind. The second thing is really more passionate, a personal passion of mine, is education. We think there's a big opportunity to have the Health Equity Tracker serve as an academic platform where we could do curriculums on not only health equity, but equitable data. And one idea that I really love, and I've kind of, thought a lot about, when I was in graduate school, it's always kind of dummy data or pretend data. But here is a platform where we could use it as a platform to teach and then show real data for students to engage with and actually use researchers are using and things like that. So I think having an educational arm of the Health Equity Tracker is very exciting because we're unique in showing here's real data that you can actually learn from and use right alongside a curriculum that we hopefully develop one day. I think those were the two that are the strongest in the forefront of my mind. But I'm always open to ideas. If you have anything that you all think of, I'll put my email in the chat, and I'm always looking for great ideas.
Well, thank you for that. And JC, I want to thank you for a great presentation. Laryngitis and hurricane notwithstanding, you did a great job. I really appreciate it, as I know our audience does. I want to thank you and the Satcher Institute for making this available to us and to our community. This is outstanding work, and it's terrific to see it. We're getting applause symbols showing up on our chat, which is always a good thing. I want to also remind the audience that you're going to get a survey coming up when you leave the webinar, and please take a moment to fill it out. It's important to us. We track how we do. We want to do better. But before, just as final words, again, JC, thank you for your time and for your insights and for sharing this with us. I want to thank our audience for joining us today. Again, I encourage you to register for the Vantage Point interview next week with Roberta Schwartz from Houston Methodist. My name is Denny Brennan. This has been our webinar with the Satcher Institute and JC Gonzalez. And thank you for joining us. We're adjourned.
Thank you so much.
Thank you, JC.